everyone. Today I've picked up the topic of gestational diabetes or GDM. This is actually a very important topic and I'm trying to pull up in 5 minutes, but please go through your notes very carefully. It is defined as carbohydrate intolerance of variable severity with either onset or first recognition during pregnancy. Don't confuse it with diabetes diagnosed before pregnancy, which will be called pregestational or overt diabetes and not GDM. Now, when it comes to you diagnosing GDM, then obviously there are multiple screening, diagnostic and treatment options as multiple controversies surrounding each of them. So you can choose as per your discretion. Regarding screening, universal screening is screening all females at 24 to 28 weeks, and risk-based screening is first assessing the risk at first visit and then screening accordingly. Indian females actually fall into high risk category by this classification also, so all Indian females need to be evaluated for GDM. If at the first prenatal visit, if you find a fasting plasma glucose more than 126, random more than 200 or glycosylated hemoglobin values more than 6.5%, then don't go for evaluation for GDM. These patients are classified as overt diabetes as an exception. Similarly, fasting plasma glucose more than 92 mg per deciliter can be directly labeled as GDM with no need of further evaluation. For rest of the patients, you can have either a single step approach or a two-step approach. For single step approach, you give a 75 gram 2-hour oral glucose tolerance test to all. Two-step approach, you give a 50 gram 1-hour oral glucose challenge test as a screening, and then those who test positive are given a 100 gram 3-hour oral glucose tolerance test as a diagnostic test. GTT is done in a fasting state and GCT is done irrespective of the last meal. For these tests, the threshold values are given here. For 75 gram, you need one abnormal value. For GCT, obviously, a one abnormal value of 140, and some people use 135 or 130 is considered positive, and for 100 gram, you need two abnormal values out of the National Diabetes Data Group or Carpenter-Kuster classification. Once you diagnose the patient as GDM by any of these methods, then you have to proceed with the management. There are two groups of patients. One who can be managed with diet modification and exercise, and secondly those who need insulin. First, you start with a diabetic diet grouped with regular exercises, mostly aerobic and strength conditioning type, and then ask the patient to monitor her glucose levels. Postprandial monitoring is superior, so we usually ask the patient to note down 4 readings per day, out of which one should be fasting and other should be 1 or 2 hours after meals, and we target on a fasting plasma glucose of 95 mg per deciliter, 1 hour postprandial as 140 and 2 hour postprandial as 120 mg per deciliter. If these are maintained, we continue on the diabetic diet and exercise, and if these are consistently falling above the normal levels, then we proceed with insulin management. Again, with insulin management, there are multiple protocols available. I am listing 2 of them here. Before that, I like to tell insulin doesn't cross the placenta, and so it's safe for the fetus. One regime is 0.7 to 1 unit per kg per day. You divide it as 2/3 before breakfast and 1/3 before dinner. Out of the 2/3 before breakfast, 1/3 is regular or short acting and 2/3 is NPH or intermediate acting. Before dinner, it is divided into half regular and half NPH. Another is Baser-Bowler's approach, where you give half of the required insulin dose as long-acting glargine at bedtime, and rest half is divided as a regular insulin divided into 3 further dosing before breakfast, before lunch and before dinner. Besides this, oral hypoglycemic agents are also being given like metformin, glyburide or glibenclamide. But mark it, these are not FDA approved for this use, and ACOG though is allowing it as a second line drug, but you need the safety data to be disclosed. Regarding obstetric management of these patients, those who do not require insulin also do not require an early delivery or other interventions. But those who are on insulin demand an antepartum fetal surveillance, and you decide on labor induction or cesarean accordingly. Cesareans for indication of macrosomia may be individualized as per the case. These patients post-delivery are evaluated at 4 to 12 weeks to confirm the diagnosis whether it was GDM or overt diabetes. If they are positive at this time, they are labeled as overt diabetes. Otherwise, they are followed 1 to 3 yearly because they are at risk for overt diabetes. Before next pregnancy also, they should be tested. There is a risk of gestational diabetes to be recurrent too. And besides diabetes, these patients also have risks of cardiovascular complications. Thank you.